the very first question, I think, was sparked by something you said early on. So question number one, can you give us some open-ended questions to ask our female patients when they do score low on the ESS, but complain of fatigue and insomnia? You want me to reread that?
No, that's a great place to start. I really think it becomes with the rapport that's going to come naturally between you and your patient. I mean, we're all in this because we want to help people, and we want to do the right thing by our patients. I find that really kind of digging into their sleep hygiene, I ask them to describe onset to sleep latency. How long does it take you to fall asleep? I also will include the insomnia severity index, which is, it asks kind of questions that will pull out if this is more of an insomnia issue. I ask them if they dream. If they're not dreaming, could there be a chance that maybe they're getting into REM, losing that muscle tone, exacerbating the symptoms and waking themselves up? I ask them what the people around them are seeing. I ask them just a good description of what their sleep hygiene is. What time do they go to bed? What time do they wake up? Description of caffeinated beverages, sleep position, all of those things.
Okay, thank you. What questions can I ask someone who reports that they wake up, quote, like clockwork at a specific time every night? For example, 2 a.m., 3 a.m. every night, clockwork awakenings.
Again, there's about this big with all the sleep disorders, and it's not uncommon for people to have multiple things going on at once. So I never rely just on one screening tool. I can't stress enough, I really would encourage you, if you're using a sleep screening tool like the Epworth or the Stop Bang, also incorporate other things like maybe the insomnia severity index, which is easily found online. And I like to give the patients an analogy that they can imagine. And this is probably lost on the younger members, but when I grew up, I had the records and the record player and the nice album and the needle.
Oh, yeah.
The needle would go across from song to song. And I like to explain to my patients that that's kind of what's going on in your brain. As you're sleeping, your brain is going from stage to stage, each one just as important. But when we get to REM, we really lose muscle tone, and it's thought to keep us from acting out our dreams. It's thought that, most people, when they think about REM, they think about dreaming. That's when we dream. And yeah, that's true. We do dream, but it's also thought that perhaps it's for consolidation of memory and the separation of the emotional component of experience. So if someone tells me that they're waking up every day at 2 o'clock or every morning at 2 o'clock, it begs the question, perhaps could that be when they're getting into REM? It's something that without a PSG you wouldn't really be able to identify, but that would be the first thing that I would think. And I'd try to explain to them, that might be when you're getting into that stage of sleep, when your accentuated loss of muscle tone is waking you up.
Thank you. Next question, what screening tools or questionnaires do you use to compensate for the deficiencies of Stop Bang and Epworth in an attempt to not miss women with OSA?
Oh, goodness. I'll tell you what, the person that comes up with the better screening tool, you give them my number, because that is really something that we're all looking for. I think, the Epworth is as good as we have, really. And although it's not something that's going to identify, it's not going to be diagnostic, where it does become very valuable is looking at it over time in the same person. So if you get it and you can compare it over periods of time, you are going to see fluctuations that can help. I really think the best thing to add to your screening tool is just open-ended questions and, a very thoughtful conversation.
Okay, thank you. This is a bit of a long one. It seems to include comments from patients, so I'll just rattle it off. Quote, I just can't turn off my thoughts and just can't fall asleep. Or if I fall asleep easy, I wake up in the middle of the night and then lie awake for hours. the dentist says, what questions can I ask these patients to understand why they have these problems with sleep, or what they can do to help them fall asleep and then not wake in the middle of the night? Is that too wordy, or do you want me to do it again?
No, I think without all of that, it would lose, it would lose the message. Here's what I think is happening, because I hear that same comment or question, if you will, from my own patients. And I try to explain to them that, again, there could be more than one thing happening. You may be experiencing insomnia at the same time as obstructive sleep apnea. A diagnostic study is really what's needed. But I try to express in terms that anyone has personally experienced. I mean, we've all been driving on the road and someone cuts you off, you have that horrible sensation. And I try to explain to the patient, okay, picture your fight or flight mechanism is kicking in. Well, there's receptors in our brain that pick up when CO2 levels go up too high, which is what happens whenever our oxygen level dips too low, and it trips this natural response to protect us. And if you're a patient waking up at 2 o'clock in the morning with racing thoughts and you feel like you just want to crawl out of your own skin, well, doesn't that just feel like an anxiety attack? Doesn't it just feel like that sympathetic surge? And they may not understand the physiology behind it, but that's where, all of us can really share and kind of unpack what's going on the physiological side. Okay, this is a natural way that your body's trying to protect you. What we have to focus on is how not to trip the fight or flight mechanism to begin with.
Okay, thank you. This is always a pleasure to present that. Rather than questions, sometimes we get the following. Fabulous presentation. You've confirmed some of my clinical observations. Thank you. Next comment. Dr. Cantwell, thank you so much for tackling this topic and presenting it to us. Your presentation raises so many questions to think about. So there you go.
That means a lot to me. And this is something I'm very passionate about. If any of you have the opportunity to share information on this and want my slides, please use them, with my blessing, take it. And I've had conversations with primary care physicians that just, there's only so much one person can focus on. So I think to share this information is something that will definitely help your patients.
Okay. Here's a real question. Today, I had a 37-year-old female who was taking an antidepressant for the past 2 years and 3 months, so 27 months on antidepressant, also started taking Concerta. What question should I have asked her to see if this could be related to a sleep disorder? She has a 5-year-old daughter and is moderately overweight.
Very, very sensitively approach this. It's hard. And no one wants to say, hey, I'm a little bit fluffier than I was pre-COVID. So I can definitely appreciate the issue there. But one of the ways that you might want to broach the subject, because we all review, medications, that's being a dutiful, provider, is when you look at antidepressants change the time spent in REM. So maybe even just discussing, did you know that, what I saw on your list of medications, this is a very, very common issue. Have you noticed any issues with your sleep? And the reason I ask is because sometimes these medications, which are very necessary and obviously prescribed by a provider, but they can impact your sleep. Do you mind if I ask you a couple questions about your fatigue level and, maybe get some measurements and just a general conversation about sleep apnea? I think most people are grateful to hear that, that there is a physical reason for what they're experiencing.
Okay, thank you. I think this has been covered, but in fairness to the members, I will present every question. Question, do you recommend or can you recommend a better sleep questionnaire than Stop Bang or Epworth to capture women better?
Oh, goodness. I can't. And if you write one, I want you to send it to me. I want to be the first person to buy that from you.
We'll patent it in Canada first, and then we'll let you have it.
Yes, very good.
That's how
Fair enough.
that's how it works. Yeah, we'll keep
I
all the
think-
rights.
Yeah, just the open-ended questions, I think, will be the most
Okay.
beneficial to your patient.
Okay. Dr. Cantwell mentioned that pregnant patients were often not diagnosed or treated. How do you recommend treating these women?
Well, what I have been trying to do here, and I think you need to explore with your referring providers what they feel is best, but what we've been trying to do is just increase the knowledge base, get a level of understanding in our own patient base. When we do identify it, I am not necessarily recommending oral appliance therapy in the pregnant population. Time is of the essence. And until, we can develop oral appliance therapy where we can 3D print it in our own office and give it the same day and calibrate it the same day, I actually, for these patients, we recommend auto titrating, positive airway pressure, just because it's immediate, it's going to change. The way that we circle back to them is that, and I don't know about any of you, other women in the audience, but, and I don't want to ruin the surprise for any of you who are considering having a family, but the weight doesn't immediately disappear. So I have 3 daughters in college and I'm still calling it baby weight. So just because you're treating them with, positive airway pressure during the pregnancy doesn't mean they're not going to want to circle back to you, for oral appliance therapy afterwards. But during pregnancy, it's really essential that they are treated quickly and accurately.
Okay, thank you. This is a very large one. I'll go slowly and I'm happy to reread it for you. Question, statement, I guess it is. There's a large body of evidence showing that people who have low vitamin D levels, i.e. less than 100 nanomoles per liter, who undergo surgery stay longer in hospital and are also more likely to go back into hospital. Has there been any interest in investigating whether there are correlations between vitamin D3 levels and pregnant women and their experiences during and after pregnancy? I'll let you take that one on.
Oh, goodness. I think that is outside the area that I can speak to. I apologize.
Okay, that's fair. Vitamin D experts like Dr. Hollis and Dr. Wagner recommend women take 6,000 international units a day during pregnancy, and if possible, to start 3 months before becoming pregnant. That may also be uncomfortable for you, but I'll give it back to you.
Again, when it comes to something that finessed, I really can't speak to it. I apologize.
No, that's certainly understandable. Another question, do women have different desaturation ratios in their cycle, menstrual cycle, that can affect a PSG score? Do women have different desaturation ratios in their cycle that can affect a PSG score?
I haven't read any articles to that effect, but if someone is anemic, which can certainly happen, then you might see fluctuations in the oxygen level just based on that.
Okay. Is there a protocol for dentists to help expecting mothers? Take that and see where that goes, and I'll come back with the rest.
Okay. Yeah, I think one of the things that we can do as providers is to empower our patients with information, because oftentimes I think our patients think, well, it's just in my head, or I'm supposed to be tired. I'm short of breath, but it's just because, maybe I'm a little out of shape. Giving them information, giving them data, even providing them with one screenshot that says, hey, snoring during pregnancy is significant, is going to open up a conversation. So yeah, I think there's a lot that we can do as providers. And I think it starts with just a good understanding of the facts and provide information to our patients.
And the latter part of this, it may be difficult for you to speak to. As you probably know, in Canada, which is socialized medicine, sometimes thought as free in the States, we have 13 different jurisdictions. So we all practice in different areas with different rules. But the member goes on to say, is it our role to encourage them to see a sleep specialist, which in our province of Ontario is kind of hard to do because only family doctors can refer within the medical world. So most of us are dentists, we're on the outside looking in. So the
Mhm.
corollary to that is maybe best to give them a home sleep test, which could maybe enhance the evidence for requiring a PSG, which in some centers, and I'm in a university town with a medical school and a dental school, and you can wait a year for a PSG.
Goodness.
But it's free. It's free.
Well,
You'll have had your baby by the time you have the test, but just so you know. Anyway, take that one on, Michelle.
oh goodness. I think, this just reminds me of a story where people said that if everyone brought their problems to the table and compared, we'd all want to take our problems back. I don't think anyone has a lock on good healthcare anywhere. It's a convoluted problem. But if you can't refer directly to the pulmonologist in your area because of the guidelines there, I mean, certainly no one would encourage you to do something outside that, but maybe having the relationship with the nurse practitioner or the primary care provider and just giving them, okay, these are my findings. This is what I'm seeing.
Right.
Making it easy. I mean, think about how overworked each of us are. It has to be the same for these other providers. If we can provide a quick template, this was the ESS, this was the ISI, this was the neck circumference, this was the chief complaint. What do you think?
Yeah. No, I hear you loud and clear, and hopefully that answers our members' question.
Great presentation.
Thank
Oh,
you.
thank you.
I think there's many hard things for me, but it's one thing to have information. It's another thing to have it accepted by the medical community. And that's where I'd like to see a lot more effort from the medical association to bring us all together, because, it's like the person who I send my patients for sleep studies, he won't even meet for lunch and I'll pay. He just doesn't want to talk,
Yeah.
But, there's not much I can do about that if I can't help educate.
Yeah.
Right.
Well, if I may, I made every mistake in the book. So, and it should probably be 2 or 3 volumes for the number of mistakes. But what I found helped me was actually, rather than trying to reach out to them directly, I hired a respiratory therapist instead, and it was about the same salary as a hygienist. So I had someone who was semi-retired, knew all of the people in the area that practiced sleep. And I hired her 1 day a week just to help me. And she ended up going around to different offices and they opened their doors because they knew her. And I don't know, it might be different, obviously, where you're practicing, but the pulmonologists are so overworked, and they're in the tumor clinic, they're in the ICU, they're in the operating room. The hand that rocks the cradle, for us at least, is actually the nurse practitioners. And I found them to be very receptive, when I would try to talk to them, especially about this topic, because many of them are, interested in trying to learn new and better ways. So, but you're not alone. It is very hard to reach them. And if they won't take up your offer on lunch, I'll come up and
After we open the border.
after we open the border, yes.
After we open the border, which is going to be closed again soon, I think. Well, most of us in Canada have been in the States many times for this on our postgraduate training. And my observation about the practice of medicine and dentistry, but specifically medicine, on both sides of the border, we kind of know the same thing, and we all practice as physicians and dentists pretty much the same. But because of the delivery system being so much different in Canada, being socialized, I basically have said that medicine's the same in North America, but in Canada it's a bureaucracy, and in the States it's a business. And you folks think about it that way, and we don't have to, because well, we dentists are because we're
Yeah.
private practice, but the physicians, the medical world, they're government employees. They work for the government. They don't answer to anybody. They don't even have to be nice to you because you don't pay their bill. And listen,
Yeah.
I'm a specialist, quote unquote. I just see patients all day long who tell me stories like they won't even talk to me, or because of COVID, they use all kinds of excuses to do a Zoom call, or I get like 4 minutes for, in Canada, you have to make an appointment for each complaint. Oh, left shoulder, that's the next time. It's crazy. So
Wow.
there's many times we'd love to be working next to you in Pennsylvania, because once you get the system figured out, it works quite well, is my understanding. So Paul speaks to the fact that why would I have lunch with Alter even though he pays for free or pays for lunch? That's the problem. We can't get, this academy that we formed many years ago was meant to be a multidisciplinary big tent, coast to coast, include all of us, dentists, physicians, labs, industry, one big happy family. And you have no idea how hard it is to get to a physician to even come to a meeting. It's just, and it's not because I don't try, and it's not because our members don't reach out. We're just an island, and it's miles from the shore of medicine. And so I share Paul's concern, and there are many times we wish we could set an office up down the street from you, because there would be collaboration and respect, and hopefully a better level of care for our patients, which is what we all strive for. Sorry for interjecting there, Paul, but I just thought I'd add that little comment.
You took the words right out of my mouth. I do have another
Short question. Okay.
So I would say that in my years, I've met a couple of staff members who, let's say, had gestational diabetes, and then I guess maybe as a male, I tend to think, well, if pregnancy stops, it will stop, and yet it doesn't necessarily stop. So can you sort of straighten me out there? Because the pregnancy is not a permanent situation, but it seems that the physiology, like, is it uncovering something that that might have been there, under the covers, and now it's come out? Is that what's going on? Is that why it sticks around?
It certainly could be. I think I also have colleagues that have experienced that. I have a very dear colleague who runs rings around us in the gym. You would think this person is in the best possible state of health, and exactly that, just diabetes, and has delivered, but is still now diabetic. So I think, we can just assume there's permanent damage done. There must have been underlying genetic factors, and, the pregnancy really brought it to the forefront. But yeah, I can only describe that from a personal perspective and not from, clinical data, but it is certainly something I've seen as well.
Okay, thank you, Dr. Alter. Anyone else for an oral question? I see a few regulars still here. Well, then, in the absence of that, let me just say that we very much appreciate you coming tonight, Dr. Cantwell. You know also of my military background, so you were actually recommended to me by a Canadian military dentist who saw you in a program in the States, and you rose to the rank of lieutenant commander, was it? That's a Navy term, isn't it?
Yes, and I saw Glendy here.
Okay. I'm here. I'm just, protect the innocent. Yeah. In Canada, we only have one armed forces, so I got to serve in the Navy and the Army. And my first posting on board a ship, months after I graduated in Halifax, which was our Norfolk, Virginia, but we only had one submarine and 3 ships. I was sent to HMCS Protector, which was the mothership. It was a supply ship, and I was coached by the other ranks with how to approach a ship, and I was brand new. I had 2 gold bars on my sleeve, and I was a captain, and I marched up, and they said, "Now you come to attention, you salute the flag, and when you're greeted, tell them who you are." So I waited for so-and-so to come, and I saluted the flag, and I announced my arrival. I said, "This is Captain Rawson reporting for duty, sir." And he said, well, Captain, I just want you to know something. There's only one captain on this ship, and you never want to meet him. He's up there in the top, and just while you're on board, you're going to be sub-lieutenant. And so I got to know a little bit how the Navy worked as an Army dentist. Excuse me, we don't have the forces that you do, but it's nice to have a kindred military expert in dental sleep medicine with us. I want to thank you so very much for coming. I don't see any hands. There's no more written questions. That's usually a sign that I should stop talking and call the meeting to an end at 8:47. You all know that you'll find this whole completely edited presentation on our website in a few days. I want to wish you all the best for Christmas and the holiday season, and we'll reconvene in mid-January. We have a very big program to launch, so stay tuned. Go on the website, do the forum, do WhatsApp, reach out to Bianca for help, and thank you, Dr. Cantwell. And we will make sure that we bring you to Canada when we can do that in a
I'd
safe
love that.
in a safe environment. You're not that far away, actually. You're just across the border.
No,
We can send a Navy ship to get you. That's what we'll do.
oh my goodness, now that would be a trick. I want to thank you again. And I also want to thank Glenda. Thank you for submitting my name. This was such a joy to do. And I really appreciated you recommending me. And Dr. Rawson, thank you so much for your generosity with your time. And you've made me very, very comfortable. So thank you.
Consider yourself an honorary Canadian, my dear. And
Yay.
we'll look forward to having you back.